next, I'll request our first speaker, Dr. Jyoti Matalia, to come and start her talk on optical interventions for myopia. We'll now go on to the next part of the symposium, which is on childhood myopia management, an extremely pressing need and an important topic of discussion now world over and increasingly gaining importance in India. So we'll start with the optical interventions that are available for us in the management of myopia, and there are now significant number of them increasing our repertoire of management. So Dr. Jyoti, please. She's from Narayan Nethralaya, has a huge body of research in this area and with a large patient follow-up. So Dr. Jyoti, please.
Thanks, Dr. Rohit, and thanks for inviting me to be a part of this childhood symposium on myopia. So as we are aware, we are coming out of a COVID pandemic. We have issues that are going to be coming subsequently, and that we are talking about is myopia. And myopia is now going to be progressing significantly. This is the global prevalence, and what has been studied is that almost 50% of the patients are going to become myopic by 2050. That means 1 out of every 2 patients will be a myope. And of that, 10% are going to have high myopia, and we know what the implications can be. So what we are going to be discussing today are the various options of myopia control, and what I will primarily talk is about the role of optical interventions in myopia. So let's understand what are the theories of myopia progression. One is the feedback, the emetropization, which is common that we are aware as the child grows. Then the dopamine, low dopamine is known to cause axial elongation, and similarly, a lot of issues with scleral biomechanics, which can also be an implication. Accommodation lag, and one other option, that is a peripheral refraction. And I'm going to be primarily talking on this because this is the concept behind the optical intervention. So what do you mean by hyperopic defocus? So when you have using a single vision glasses, you know the central part is focused on the retina, but the periphery gets focused beyond the retina. That is a hyperopic defocus, and that is the reason why these patients can have myopia or axial elongation. That is the important. And for that comes the defocus devices, where peripherally, there are certain areas of defocus in your glass which causes a myopic defocus, and this myopic defocus can prevent your number from going up, and that is the concept behind these devices. And for that, we could have various options, like we have the defocus glasses, that is the peripheral defocus ones, and the contact lenses. But let me first enumerate which are the various optical treatments options there. So we have the options of glasses and contact lenses. Glasses, there are the single vision with undercorrection or progressive addition lenses, but they're of no use now in trying to control the myopia progression. So what we look at is the defocus or the contrast alternating ones. In contact lenses, we have the options of rigid contact lenses or the orthokeratology, or the soft bifocals or the multifocal contact lenses. So I'll try to talk on each of them. So looking at the spectacle options, we have 4. That is a defocus incorporated multiple segments by Hoya, that is a DIMS. We have the highly aspheric lens sets, that is HALT, that is by the Stellist, that is introduced by Essilor. The diffusion optics technology DOT by Essilor, and cylindrical annular refractive elements CARE by Zeiss. So let's look at each of them. So this is basically a glass which has a central clear zone of 9 millimeters, that is for distance refractive correction. Beyond that, there's a 33 millimeters of area where there are 400 multiple defocus segments, each diameter being about 1.03 and having a plus 3.5 myopic defocus, which is fixed. And this is meant to act along with the central, causing a myopia defocus, therefore preventing the axial elongation. Then second, we are looking at the Hall technology, that is the Stellist, where as you can see inside, there is an exactly a myopic defocus, entire bowl volume of defocus produced by the glasses. That is the A in front of the B, where is the focus on the retina. And what it has is 11 segmental rings, as you can see. But here, the amount of myopic defocus is not fixed. It can vary depending upon your central refractive correction. Then comes the diffuse optics technology. This is different. What they say here is that the abnormal contrast between the cones in your retina can be responsible for axial elongation, and this is what it does. So the central part continues to be fixating and has the correct refractive correction, but around that there is a significant low contrast, multiple dots, which probably would eventually prevent this myopia progression, and this is still not come in, and it's in the process. And finally, the CARE, that is the cylindrical annular refractive elements by Zeiss. These you can see are multiple cylinders which are there, which cause the myopia defocus. They are incorporated on the anterior part, and this defocus is what will prevent the axial elongation. Thus, we have 4 options, and you can see these 3 options primarily are considered with the defocus principle, that is the myopic defocus they create, whereas this talks about modifying the contrast. Now then we come on to the, let us understand all whatever we are talking about, what is available is the DIMS and the Hall technology where we have a lot of papers, Zeiss is coming into it. But what it primarily shows that there is a slowing down of myopia progression by 60 to 70%, more so in the Chinese population. Unfortunately, we don't have any proper publication which talks about Indian population. Also now coming to the other aspect, contact lenses. So here we are looking at two options. One is the ortho-K. These are the night wear contact lenses where you can see an ortho-K is like this. The child wears the wears the contact lens, sleeps throughout the night, minimum 8 hours required. In the morning there's a modification. The advantage being that the next day he doesn't have to wear any lenses or glasses for the whole day till he wears the night wear contact lenses. So children who are not interested in glassware throughout the day, this becomes a very important option. Then the other options are the soft CLs, that is the MySight or the AIOC2024, where you have these are basically daily wear contact lenses, where they have the same concept of treatment zones creating myopic defocus versus the correction zones. So both are the same concept that you work on. But we have to know that there is a certain limitation when you order any of these. So the spherical equivalent of all should be less than -10, and the maximum cylinder for the DIMS and HALT is about -4. Regarding ortho-K, not more than -2 is what is allowed when you basically decide to order it. So to summarize, what are the various options to include for myopic defocus? We have the DIMS glasses, the Stellase with the Hall technology, the CARE by Zeiss, the ortho-K and the soft OK, which are presently available. But unfortunately, there are no optical treatments, though we have multiple long-term studies in terms of Indian scenario are necessary and we don't have it. And it's a need that we all collect our data and get information of how they are doing. But incidentally, now that we are talking about peripheral diffraction, I would like to give you the data that we have been using. We have an open field autorefractor which have been used where we make the patient look at distance and do the peripheral diffraction. And what incidentally we found that we have about 54% who have myopic defocus. So what we are assuming that is the peripheral diffraction having a hyperopic defocus causing myopia progression is then not sure, because we are getting more of these patients with myopia progression having a myopic defocus. We have only 46, so comparatively we have more patients having myopic defocus. Also what we noticed that the amount of progression noted in both the groups were same, those who had the MD versus HD, and we found that majority of these patients were having in the nasal field in those with myopia progression, whereas those with the temporal hyperopic defocus had in the temporal quadrant. So what we do is the advantage of doing this, and I just want to tell you, even if we have the machine, this can be done even without a machine. All you need to do is train your optometrist to make the child look in the particular direction to induce a 20 degrees and 30 degrees nasal and temporal quadrant. And if you're able to do that, you can plan the treatment option. So we had totally 228 cases, of which 122 had myopic defocus and the other ones had 106. And then we decided to alter it. Now, as I said, average difference was about 1.3, and you can notice that we had myopia defocus as high as 4.6 in 1. So it can be significantly high, not like marginal. And hyperopic defocus was as high as 7. So what we did is those we had myopic defocus, we treated them with low-dose atropine. Some of them insisted on glasses, so we give them to them, and we had 11 who refused treatment. But for hyperopic defocus, we definitely give glasses. We know it is definitely going to work in them, so we had about 50% of them giving the glasses, ortho-K in 3 of them, and low dose in 4. But some of them refused, so we kept them on treatment. But what you need to do is, irrespective of whatever treatment modalities you give, lifestyle modification is very, very important. We cannot just give these glasses and expect the child to be constantly indoors, not going outdoors, constant near time. So this is very important. In addition to your treatment, please reinforce lifestyle modifications. So this is our data that we have been collected. This is done from Jan 2023 to December, and hopefully for the next years, I will have better data to tell what we did and how these patients behaved. So thank you very much.
Thank you, Dr. Jyoti. Do you have any comments from the panel? And meanwhile, I would request Dr. Rohit Saxena to be ready with his presentation, in which he will be speaking on unanswered questions on myopia.
Ma'am, I just wanted... Hello. I wanted to know your experience with ortho-K, if ortho-K lenses.
So presently we have given about 60 patients with ortho-K. This was before our peripheral, and we are finding that they are doing pretty well. But unfortunately, our data is less than 1 year. So what we hope to do is all this data where we have collected of glasses, even atropine, we are quite aware, we are following up. We will probably present in the next, another 6 months later we'll have, but we have none of our patients actually on whether it is a glass or it is an ortho K, had to be given any additional treatment. But what we tend to follow is every visit that they come, we ensure that we are calling them every 4 months. We get the axial done at each visit. And we ensure that the lifestyle is reinforced each time, because many a times that's forgotten. We give treatment, we don't try to reinforce. It's like a diabetic patient. You are giving him medications, but if he continues to eat everything, he's not doing exercise, it will work the same way. So this I keep on reinforcing. One thing that I would like to tell about ortho K is that when you are introducing ortho K, you've taken the axial length prior, 1 month post ortho K, please get the axial length done again, because it can modify. And then what you follow up the patient will be on that measurement of your axial length for your subsequent visit.
You are Dr. Jyoti.
Ortho K with low dose at
It's not on, ma'am. It's not.
Oh, yeah, that's. Hello. Yeah, studies have shown that ortho K, combining ortho K with low dose atropine has about 55 to 58% better results than only ortho K.
But I would always start one intervention, wait for it. If I'm able to show that it's progressing, it's better to add the other one. Right.
Yes, sir, you have a question.
Dr. Jyoti, you said that the refractive index of these polycarbonate glasses is 1.59.
I'm sorry, I didn't get.
Refractive index of this polycarbonate glasses is 1.59. You are told in your...
No, I didn't mention anything about refractive index. I just told...
1.59 you have mentioned, no?
No, I have not. No, I have not mentioned about the refractive. I was just talking about the amount of changes that hyperopic defocus, the amount of diopter defocus. I have not mentioned about refractive index of any class.
1.59 you have mentioned in your just slide.
You can go ahead with your question, sir.
Yeah.
Any question related to that?
My question is, normally the refractive index of 1.59 is there, which are 1.5 millimeter thick polycarbonate glasses. We come across sports personnel, a child is there who is playing sports and all. In that, even 1.5 millimeter polycarbonate glasses may not be good enough. We may have to give 2 millimeter or even 3 millimeter. There the refractive index becomes more. Instead of, normally it is 1.59, which glasses we are using usually. There refractive index goes to 1.71. So can we use, will it create any problem? If we use 3 millimeter thick polycarbonate glasses, which have got refractive index of 1.71, so
Yeah, I don't think
will we
that-
tolerate it?
Yeah, the thickness of glass for protection, I don't think would make any difference. What we are
No,
trying
it
to...
makes 1.5 millimeter is refractive index 1.59. If it is 2 millimeter, it goes to 1.61. And if it is 3 millimeter, it goes to 1.71. 1.69 or 1.71. Refractive index do changes.
But I think
with
that
the
would not
thickness.
really bother in terms of the myopia progression. What we are looking is changing the parameters to prevent
No,
a
what I
progression.
want to say, you are the polycarbonate glasses which we are giving. I want, there are many children which we come across who are playing sports also there. So for them, we advise polycarbonate glasses, but it should be 3 millimeter thick.
Okay, yeah,
So
okay.
this
yeah.
is going to create any problem if the refractive index changes. The refractive index is the main thing. Glasses, it is 1.5.
Sir, there are two different things we are actually talking about. We are talking about myopia glasses which have a separate, which are conventional, built on conventional lens material. The polycarbonate glasses for sportswear are different, so that time the myopia, depending upon
Those
the
who are
thickness and
myopic.
protection. So they need not wear, in fact, they should not be wearing these very expensive glasses while in sports, because it is a heartbreak to the parents if 18,000 glass gets broken when the child is playing cricket. So in fact, that's what we advise, that when the children are outdoors playing active sports, they should switch back to their conventional glasses. Studies have shown about 8
rather
hours
in
of...
sports, polycarbonate is there because
Sir,
polycarbonate is
glasses
8
are
times
for
strong.
sports and protection. They have nothing to do with myopia progression. So here
Okay,
we are
nothing to
focusing
do.
only on myopia
But
progression.
they are very strong and they are advised for sports.
Wonderful,
personnel.
absolutely, sir. You are absolutely right. We should ask them to wear polycarbonate for protection.
I think we
Sure,
can
sir.
go for
Thank
the
you.
next. Is Dr. Ming Wang He in the audience?